So I just want to start by saying thank you to everyone for joining us today, both our coalition partners who will be speaking and members of the media who are covering the last days of this legislative session. I'm Emily Beauregard. I'm the director of Kentucky Voices for Health, and we're here today because the Kentucky General Assembly made major changes to Medicaid through House Bill 695 in the final hours before the veto period started. Without having time for public knowledge or input before the bill passed through both chambers, we wanted to bring attention to the bill's implications and potential harms, including its effects on Kentucky Medicaid members, our communities, our workforce, and our healthcare system. I'll start with a bit of background on the bill and its impacts, and then I'll introduce each of our speakers to share their concerns with House Bill 695, and we'll have time at the end for questions and discussion. As a coalition led by consumer voices, we are acutely aware that most Kentuckians are simply a lost job, new baby, accident, or illness away from qualifying for Medicaid and other safety net programs that exist to catch us when we fall and sustain us while we get back on our feet. We also know that Kentuckians who are looking for work, working multiple part-time jobs, struggling with an illness, substance use disorder, or other barriers to economic security are more likely to find or keep a job or even get a better job when their basic healthcare needs are already being met. House Bill 695 puts our safety net and workforce at risk by adding costly administrative red tape to the program that would end up providing less healthcare to fewer people. This bill does that in two ways. First, it requires the Cabinet for Health and Family Services to implement a mandatory community engagement program, which would likely require regular reporting of work or other approved activities in order to maintain Medicaid coverage. This requirement is intended to apply to Medicaid members between the ages of 19 to 59 who are mentally and physically able to work and who are not primary caregivers of dependent children or a disabled adult relative. And on the face of it, the expectation for Kentuckians to work and contribute to their families and their communities sounds like common sense. It's certainly a goal we all share. But in reality, a work reporting requirement is the opposite of common sense. The paperwork and administrative red tape will actually make it harder for people to get and stay healthy enough to work. Terminating someone's health care for not reporting will only make them sicker and less able to work. That's not common sense. We have to recognize the realities real Kentuckians face in working low-income jobs with fluctuating hours or in being unable to work for legitimate reasons. Labor data tells us that 96% of Kentucky adults enrolled in Medicaid are working full or part-time, caregiving, living with a disability or illness, in school, or retired. Another 2% are looking for work, and we don't know the status of the final 2%. Any intervention here should be surgically targeted to that 2 to 4%. But we've seen the community engagement mandates attempted in Kentucky and other states like Arkansas and Georgia. What we've seen with them is that nearly everyone gets caught up in the administrative red tape, and it costs more to cover fewer people. When attempted by Governor Bevin in 2018, mandatory work reporting requirements were estimated to cost Kentucky over $17 million in state funds and $170 million in federal funds. At the same time, they were anticipating the requirement would terminate coverage for 95,000 Kentuckians. Luckily, that plan was stopped by the courts. We've seen mandatory requirements fail in other states too, never delivering on their promises to save money, improve workforce participation, or lead to better paying jobs that provide employer-sponsored health insurance. What they are good at doing is terminating coverage for paperwork reasons, putting families at risk of medical debt, and leaving providers with more uncompensated care. And while we recognize there are exemptions in this bill for caregivers and Kentuckians who are physically or mentally unable to work, the truth is that exemptions are complicated, particularly for people with disabilities or mental illnesses who may not be able to navigate the paperwork requirements and will end up falling through the cracks. But we also worry about Kentuckians experiencing domestic violence or homelessness who may not be in a safe or stable enough position to consistently receive mail and complete paperwork. Any way you design it, exemptions fail to protect everyone. The second way this bill creates more red tape and reduces access to care is through the wholesale reinstatement of prior authorizations for all behavioral health services that required a PA before they were suspended during the pandemic. We know from years of experience that prior authorizations can delay access to care. For conditions like depression, anxiety, and substance use disorder, early intervention is crucial to improving health outcomes and reducing the need for higher cost services down the road, such as emergency room visits or inpatient hospitalization, all to the patient's detriment and at an increased cost to our healthcare system. And let's remember that behavioral health care is absolutely essential to a person's ability to work and take care of their family. So the speakers I have here with me today are going to be expanding on these issues and the impact House Bill 695 will have on their patients, their communities, and on the healthcare providers, nonprofits, and churches that are serving them. So I'm going to start by introducing Dr. Sheila Schuster, Executive Director of the Advocacy Action Network.
Good morning. Glad to be with you all. The Advocacy Action Network has two organizations that are impacted by House Bill 695. One is the Kentucky Mental Health Coalition, 80 organizations and 43 years old, and the other is the 874K Disabilities Coalition. It is a cross-disability coalition of more than 874,000 Kentuckians who have at least one disability that interferes with the task of daily living. These so-called cost-saving proposals that Emily has just referred to are particularly of concern to people with disabilities. The first is the return to full prior authorization for Medicaid behavioral health services, which were suspended at the start of the pandemic. Let's remember that prior auth, as we call it, is only a cost-saving measure. It contributes nothing to the improved quality of services that are offered. It results in delays or in access for the patient and barriers to services. And importantly, it takes clinicians such as myself away from direct provider care as we hassle with prior authorization justifications, endless faxing, endless research that has to be submitted. Prior auth is particularly problematic for those who suffer with addictive disorders or mental illness, where a delay often results in the patient leaving without getting the needed services, only to have the condition worsen, resulting in more extensive services needed later at a higher cost to patient, provider, and system. The second cost saving, so-called, is the mandatory community engagement. As Emily has pointed out, it's really not necessary since 95 to 96% of individuals on Medicaid already work or are caretakers or students or unable to work. And let's remember that disabilities are not always visible. We get a lot of talk from legislators about able-bodied, and to look at some of our folks with substance use disorder or mental illness, they look able-bodied, but they are not. They are not mentally fit to be able to go to work. Our experience in the Bevin administration was incredibly complicated in reporting requirements, very difficult to meet, often resulting in people losing coverage, but not because they weren't working, was because they could not comply with the paperwork requirements. We advocated for exemptions for our folks with disabilities, and they responded by creating a medically frail category, an incredibly pejorative, stigmatizing description for an already stigmatized group of people. It took provider time to complete the necessary paperwork to try to get that exemption for our patients, only to have the MCOs not be able to verify because it didn't fit their algorithm. We were left with a lot of confusion, incredible time wasted, and individuals on Medicaid in constant fear of losing their coverage and access to services. I don't think you need a doctorate in psychology to know that when you create that kind of anxiety in an already disabled group of people, it worsens their condition, particularly with mental illness and substance use disorder. So in summary, the cost-saving measures like prior authorization and mandatory work requirements create more red tape and end up saving money only by serving fewer individuals. Thank you.
Thank you, Sheila. Next up, I'm going to introduce Michael Stanley, CEO of Grace Health.
Good morning. I'm Michael Stanley, CEO of Grace Health. It's a community health center serving over 44,000 individual patients in Laurel, Knox, Whitley, Clay, Bell, and Leslie counties. Grace Health provides the following services: medical, dental, behavioral health, women's health. We're delivering over 1,000 patients a year. Pharmacy services, school-based health. We're in 34 schools in Eastern Kentucky. Substance use disorder outreach and enabling services. So Grace Health is one of 28 community health centers in Kentucky. We care for over 646,000 individual patients, and more than 11% are uninsured patients. So Kentucky Community Health Centers serve over 34,000 homeless and over 9,000 veterans. Nationally, community health center savings to the system are about 24% lower cost for health center Medicaid patients. That amounts to $38.6 billion in savings to Medicaid by keeping patients healthy, avoiding unnecessary cost. So over $59 billion in savings to the overall health system and $14.3 billion in annual tax revenues from community health centers. So over 40% of our Grace Health patients are covered by Medicaid. With expanded Medicaid, our quality clinical performance measures show that the communities we serve are healthier. The loss of expanded Medicaid and a work requirement could reduce our Medicaid covered patients by 10 to 15%, with a loss of $2 million to $3 million in Grace Health revenue. A loss of this magnitude would threaten our behavioral health, school-based health, substance use disorder, and dental services. Typically, those services are underfunded. The result of losing Medicaid coverage will lead to decreased access to necessary health care, worsening existing health conditions, and even creating new ones. The implementation of work requirements for Medicaid patients, such as those proposed in Kentucky, have been shown, like Emily has shared, to have several unintended consequences. These consequences often stem from the complexities of populations served by Medicaid and the administrative burdens associated with such requirements. I have a summary of some of the key issues. For example, loss of coverage for eligible individuals. Like shared with Dr. Schuster, as many individuals who are eligible for exemptions already working may lose coverage to difficulties in navigating the reporting requirements. And this can be due to factors like complex paperwork, lack of digital literacy, or fluctuating work hours. It's also been shared the increased administrative burden and also the negative impacts on health outcomes. Like I said, losing Medicaid coverage can lead to decreased access to necessary health care, worsening existing conditions and creating new ones. And there's also challenges for our low-wage workers. Medicaid beneficiaries often work in low-wage jobs with unstable hours, making it difficult to consistently meet work requirements. This can create a cycle where individuals lose coverage due to factors beyond their control. And also, one of the things that we don't think about is the worsening of the opioid crisis. For those suffering from opioid addiction, losing Medicaid coverage can cause decrease in access to treatment, thus making the opioid crisis worse. So in essence, while the intent of work requirements may be to promote employment, the reality is that they often create barriers to healthcare access, particularly for those most vulnerable populations that we serve. Thank you very much.
Thanks, Mike. Our next speaker is Tim Cerio, Substance Use Disorder Director at Cumberland River Behavioral Health.
Thank you, Emily. I don't know how you follow Mr. Stanley and Dr. Schuster and yourself and how well you've articulated what the problems are going to be. Cumberland River Behavioral Health is a community mental health center, which is often referred to as the safety net for behavioral health in our region. Okay, we're located in the 5th Congressional District, where approximately 40% of the population receives some type of Medicare coverage, and approximately 60% of children are covered by that. My concern lies in the work requirement and how that trickle-down effect is going to lead to some unintended consequences, leading to parents who in the substance use field, we encounter a lot of people that have never had regular work and have not developed the skills to maintain a full-time job or what we would call a regular job. The reporting requirements, I believe, will cause a hardship, especially when you consider that the 5th Congressional District is not like a bustling manufacturing area. It's the ability for people to find steady, full-time traditional work is not always available. Many people in the Appalachian region and in the 5th Congressional District work side jobs, work odd jobs to make ends meet and rely on Medicaid for healthcare coverage. The trickle-down effect is if the parents lose coverage, then the children are going to lose coverage. So we're not affecting one generation of Kentuckians, we're affecting 2 or 3. The pre-authorization, the impact of implementing pre-authorizations for all services is, again, it's going to be cumbersome for the providers. Often we have people who are ready to engage in services today. And if we have to go through the pre-authorization process to allow people to access services in 3 weeks, that interest and that desire to receive help may be gone. It may wane. So we have a concern about that. My experience over the past 5 years with the residential treatment centers that we operate is that having services pre-authorized is not only cumbersome, but it often isn't met with objectivity on the part of the managed care organizations. Again, I've heard the phrase cost savings a couple of times today. And while pre-authorizations do indeed save costs for the MCOs, it creates hardships for the treatment providers. Often the treatment providers are left with the dilemma of whether or not to provide treatment services for this person free of charge, or how we're going to maintain the ability to provide services altogether. And that's pretty much summarizes my concerns about this whole bill. I hope that the legislature will look deeper into what the long-term impacts of passing this bill would be.
Yeah, thank you so much for being here today, Tim. Our next speaker is Adrienne Bush, Executive Director of the Homeless and Housing Coalition of Kentucky.
Good morning, everyone. Thank you, Emily, for the introduction. HHCK is a statewide organization working to ensure that all Kentuckians have a place to call home. Since 2014, Kentucky Medicaid has been a lifeline to healthcare for people experiencing homelessness and housing insecurity. When we talk about housing with wraparound supports as the way to solve homelessness, we include Medicaid as one of those critical supports, connecting people with primary care and behavioral health care services without prior authorization barriers when appropriate. Since people experiencing homelessness are at greater risk of both chronic and acute medical conditions and even mortality, a program that covers the costs of their healthcare needs is a good investment for the individual, the community, and the Commonwealth. Unfortunately, reporting requirements above and beyond the federal requirements to establish and retain eligibility serve as a barrier that would, in effect, disenroll people who are eligible. When you have no fixed address to receive mail or sporadic access to a Connect account, it is difficult at best to receive and report work or community engagement activities while to maintain coverage. Even if you can report the activity while trying to figure out where you're spending the night, it may fall to the bottom of the to-do list. I also want to note that it helps many Kentuckians who used to be homeless or are at risk of homelessness due to high rents despite working and being involved in their community. Losing health insurance will pose an additional cost that Kentuckians can't afford and will put them at risk of losing their housing again. I also wanted to share with you remarks from Marilyn Smith, director of Gateway House, a homeless shelter in Moorhead. She writes, in my experience, the work reporting requirements for Medicaid participants would create significant challenges for individuals experiencing homelessness. The proposed requirements reinforce the cycle of poverty and reduce the chances of escaping homelessness. Homeless individuals often face barriers like unstable living conditions, lack of access to transportation, and limited access to communication tools. These make it harder to report work hours consistently or comply with administrative rules if they are lucky enough to find stable employment due to factors like lack of a permanent address, gaps in employment history, or health issues. Work requirements may not account for these obstacles. Some homeless individuals struggle with mental health issues and/or substance use disorders and rely on Medicaid for survival. Without adequate support, mental health challenges and addiction can worsen, making it even harder to find stability or work toward permanent housing. If funding for behavioral health and addiction recovery services is reduced, they could lose access to essential treatments like counseling, therapy, or medication-assisted treatment through either the comp care system or a licensed behavioral health services organization. The ripple effect of these limitations will also create further strain on community resources like us and other homeless shelters that often try to fill the gaps when state programs fall short. It's a complex issue with far-reaching implications. From HHCK's perspective, we want people to be safely housed in a home they can afford with the services that they need. Medicaid is a critical component of those services, and the provisions of House Bill 695 will undermine our collective efforts to move folks into and keep them in housing. Back to you, Emily.
Thanks, Adrienne. Our final speaker is Jason Hall, Executive Director of the Catholic Conference of Kentucky.
Thank you, Emily. I'm here today because we strongly support the goal of the Medicaid program, which is to provide access to health care for vulnerable and marginalized individuals and families. Our tradition, the Catholic tradition, teaches us that health care is a right, and Medicaid is one of the ways we seek to honor that right in the United States. We certainly understand the need for reasonable measures to ensure that public resources are being spent wisely. Care should be taken, however, to avoid undermining the goal of the program itself. As has been stated by others on this call, most Medicaid recipients do work, and of those who don't, almost all are students, caregivers, or ill or disabled. Without actually solving a real problem, these work reporting requirements could result in eligible Medicaid recipients losing their coverage, especially at difficult times in their lives when healthcare access might be most needed. As we have seen in recent years with the high rate of utilization of vision and dental benefits and the need we all recognize for accessible treatment for substance use disorder, accessing healthcare is often a prerequisite to entering or returning to the workforce, not the other way around. We want all Kentuckians who are able to become self-sufficient. That's a goal we share. Providing access to healthcare is one of the ways we do that. Healthcare is a necessity, not a reward. Thank you.
Thanks, Jason. I'll just wrap up by saying and really reiterating what I've heard a lot of you say today. We all want our families and communities to thrive. And there are ways for Kentucky policymakers to approach cost savings within Medicaid that doesn't hurt people, that doesn't reduce coverage. And some of those options are investing in more employment training and resources, addressing the transportation and childcare barriers that make it difficult for many Kentuckians to find and keep work, and establishing a basic health plan so that the benefits cliff isn't so devastating. So for all of the reasons that you've heard here today, we urge the General Assembly to reconsider House Bill 695 before the session ends. And with that, we are available for questions and discussion. If you have a question, you're welcome to come off mute. Yeah. Can you hear me? Yes. Hi, Sarah.
Hi, this is Sarah Ladd with the Lantern. This is really for anyone, but I was talking to Senate President Robert Stivers this morning about Medicaid, and part of the rationale he kind of outlined for passing this latest version of the Medicaid bill was he said he didn't want people who were on uh, public insurance to have a richer benefit than people on private insurance. Is that ever the case? And if not, where does that idea come from?
That's a new concern that I've heard, that I'm hearing now, I should say. Here's the thing, people with commercial health insurance or with any other type of healthcare, Medicare, Medicaid, we should all expect to have the type of care that we need when we need it. We should have access to those services when we need them. And to suggest that Medicaid is a better benefit than commercial insurance, to me, says we need to expect more of commercial insurance. But I don't think that anybody with Medicaid coverage is getting services that aren't medically necessary. And we hear oftentimes that people do struggle with access to care for other reasons. So no, I would reject any notion that Medicaid benefits are, too generous.
I would also add, Sarah, this is Sheila Schuster, that access to services, if you're Medicaid covered, is not always great. We have a dearth of providers. You've heard about this for years in the dental community. Quite frankly, we have a dearth of providers in behavioral health. If you look up providers, let's say in the city of Louisville, unless you go to the community mental health center or to an FQHC, you have very limited choices. And it's because the Medicaid reimbursement rates for providers are so low, much below the commercial rate. So I guess I would argue a little bit with that. I agree with Emily that everybody should have what they need that's medically necessary, but actually access for the Medicaid patients is probably limited, more limited than for those with commercial insurance.
Thank you very much.
Sure.
I see a question or a statement from Melissa in the chat. Hard battle to change minds with federal policy supporting this kind of policy. Can you speak to this? Well, Melissa, if I'm understanding what you're kind of referring to, we know that, Kentucky is looking, to some degree at least, looking to what is happening in Congress right now with Congress's attempts to cut funding from the Medicaid budget to the tune of $880 billion over 10 years. And one of the many kind of funding options or options for cuts on the table is work reporting requirements. But I think that in and of itself tells you that a work requirement is a cut. It's not about proving that someone is working or, doing some other kind of approved activity or eligible for an exemption. It is a way to cut cost because fewer people will be enrolled in Medicaid, and it doesn't improve health. It doesn't improve, access to work or, our workforce more broadly. And it really will only result in fewer people having access to the care that they need and an increase in uncompensated care. So we will see not only the safety net providers that we have here with us today struggling with that uncompensated care and their ability not just to serve uninsured patients, but their entire communities. We will see rural hospitals in particular struggling with this. And we've heard many times throughout the years that without Medicaid expansion or even, maintaining Medicaid expansion, but having fewer people covered because of these complicated reporting requirements, many hospitals are at risk of closing. That impacts everyone, not only the people who have Medicaid coverage and may lose it, but every single person in the community who relies on those providers. So I don't know if I'm really answering your question, but what is happening in Congress, I think, is influencing some of the decisions that we see here happening in our General Assembly. The other thing I'll say about that is it's premature. Congress hasn't come up with a plan yet. They haven't passed anything. So to think that we should be starting to make similar cuts that are being considered in Congress without them actually coming to fruition, I think is premature. And the establishment of the Medicaid Oversight and Advisory Board, which is another component of House Bill 695 in the version that passed, it was originally House Bill 9. You know, that's where we should be having some of these conversations. And I think this is just, you know, taking a step too soon and without having any evidence that it's going to actually improve health or lower cost.
I would also say, Melissa, that, you know, I talked earlier about stigma, and of course, as a mental health provider, I've struggled with this all of my career. But I think there's a huge stigma in the minds of the legislators and maybe of the general public that this is, you know, people are on the dole, that this is a handout. And you hear legislators actually say, well, they're using their Medicaid to buy beer and cigarettes. And I'm always like, who buys anything with their health coverage? You know, if you've got Aetna or Medicare or whatever you've got, it's not like you're getting a check every day, but there's that kind of, you know, the ABODs, we call them, you know, everybody is able-bodied and they're just being lazy. So I think there's a huge stigma around that. And that's why I make the point that, you know, so many disabling conditions are actually invisible. The other thing that's fascinating to me is that you will hear legislators say, well, we should never have expanded Medicaid. That's what drove up all the costs. Well, actually, we're investing 10 cents in getting $1 worth of health care because the feds are paying 90 cents. So where else could you put in 10 cents and get $1 worth of services? And I would remind them that in the first 2.5 years in the expansion, there was a 740% increase in utilization of substance use disorder services. Tim's probably well aware of that. And it's because the people that came in the expansion were poor, mostly male, that didn't have dependents and had never been eligible for Medicaid before. And in a state that is still struggling, as I know Tim can tell you, with opioids and other addictive disorders, who in the legislature would vote to take people off of access to substance use disorder? So I think it's a lack of accurate information in part. And I think they're genuinely scared of what's going to come down from the feds. I think Emily talked about that. So they're almost prematurely tightening the belt before we really know what's going to come down from the feds.
And just to follow up on what Dr. Schuster just shared, when you look at the reduction that's probably coming from this for the treatment of substance use disorders, what you end up having is less reimbursement, which means that the providers are going to struggle, which means that resources are going to go away, which means that the problem becomes bigger. And I think whenever I said earlier about looking deeper into what the impact of this is going to be, that's exactly what I'm talking about. And interestingly enough, I'm doing a seminar on stigma later today, Dr. Schuster. So, and everything you said is in my presentation. So I appreciate that.
I see that Sarah has posted a couple of questions in the chat as well. The first about, you know, streamlining work requirement reporting, how you would get sort of document and provide proof or evidence that you're meeting the requirement and what that process could look like. And then also, you know, how to distinguish this from Governor Bevin's attempt. I think it's accurate to say that the way that House Bill 695 is written, that section of the bill, the Cabinet for Health and Family Services does have some discretion in how it would create that process, the paperwork in particular, how often people would have to report. And I think all of that is potentially a very good thing. But that same discretion means that, you know, this administration could do it one way, the next administration could do it a very different way. So while I think the current administration, Secretary Friedlander, you know, I would probably want to make this as automated as possible using existing data. We have a lot of claims data with diagnostic codes we could use to identify many of the disabilities, substance use disorders, illnesses, things like that. We have a lot of, everyone has to report income to prove their eligibility. So we have income data, and if you have income, that means somebody in your household is working. We could use a lot of that. But another administration would have the discretion to require reporting and require paperwork, regardless of what data they already have in their possession. And so that is a concern of mine.
I think also, if you look at the unwinding and how many people lost Medicaid coverage because they never got or didn't understand that they had to answer this request for information, the cabinet did a great job using the already existing data, as Emily talked about. But if you have to contact somebody on Medicaid, and Adrienne would be an expert on this, if you don't have a home or some reasonable address or some place where they can get in touch with you, or, they were trying to text people. Well, does everybody on Medicaid have a cell phone? Part of this is just, this is a transient population in many cases. Things happen to them. They're living hand to mouth in a way. So if there's something else that happens in the household, they move and nobody knows where they've gone. I mean, there are a lot of those things. So even if it were a simple return, Sarah, I think of a simple piece of paper, once every 6 months or something, you're still going to lose people. And we know that from the rewinding or unwinding, I should say.
Yeah, that's exactly right. And I'll say from that unwinding process, we identified by talking with Kentuckians who are directly impacted, who were losing Medicaid coverage, and with connectors and community health workers who were assisting them, we started to see a trend that a lot of people were saying they didn't get a notice to, update their income information. And by going back and forth numerous times over many months with the cabinet, we identified a system glitch in which 29,000 Kentuckians lost their coverage for absolutely no reason other than a very unintended mistake and just a system error that was happening that no one was really noticing until we were able to sort of raise that flag. And the cabinet then dug in and really looked at the system to try to understand why certain people weren't getting those notices that were requests for information. So these things happen more frequently than we wish they did. And anytime you add a new requirement, it just has kind of a compounding effect. I saw Mike come off mute. Did you have something you wanted to add?
Yeah, back on implementing and enforcing work requirements, we do know it places a significant burden on the state agencies, but a lot that's not discussed is what happens at the local level at our clinics. Patients know us and they come to us for help and assistance. And I tell you, we just don't have the resources to meet all of those requirements and help them. We're going to try, we give it the attempt, but that takes away again from what we could be doing clinically, taking care of patients. It throws us into that work requirement and trying to help them with the paperwork. So that's another issue for us.
That's a great point, Mike. Thank you. What we see with people with mental illness is that they very often have paranoid thoughts, and they don't open their mail. They literally think that the mail is poisoned or it's going to hurt them, and so they don't open their mail. And again, unless they're coming into the Comp Care Center or into the FQHC, and somebody there can kind of hold their hand and say, "This is what you need to do," they're lost. They don't respond.
And I have to give credit to, again, our team. Our team is amazing. When it came to expanded Medicaid, they were recognized by the governor for signing up as many people as they did on Medicaid. Just the process of signing up on Medicaid is just arduous for a lot of our patients that we serve. So, again, we're the face of the community. We're the ones they know, and they come to us for the help, and we're going to try to give it to them. We just don't want to take away from taking care of their medical needs by doing paperwork.
That's exactly right. Melissa had another question in the chat about measuring the impact of this bill, assuming it becomes law, particularly around the presumptive or the prior authorization requirements. And I do think through claims data, we could look at how prior authorizations change utilization. I don't know, and maybe Dr. Schuster or Tim could speak to this, if it would really reveal to us the delays in care as much as what is approved or denied.
It's really a tough question, Melissa, because it's hard to measure that. I think providers will try to keep track of how long it's taking to get those requests approved. You can count the number of faxes that you have to send in on a particular request and so forth. The other way is that because there has not been prior authorization for the past 5 years, the MCOs have literally driven providers crazy by doing incredible numbers of audits. And their rationale for that is if we don't have prior authorization, then we're going to come back and after the fact, look at all these records. And we have people that report to us in the larger clinics, some of the community mental health centers, some of the FQHCs, that a single MCO will say, send me 700 records of your patients, and you have 10 days to reply. And so, now that we're going to go back to prior authorization, you better believe that those same providers are going to be looking to see whether at least the onerous requests for audits for those patient records. Now, that's not exactly a quality index, except that it takes away from staff time. The problem is that you don't need clinicians to Xerox patient records. You need a clinician to respond to the prior authorization. And if we had a good way of providers counting literally the number of minutes that they spend on each prior authorization response, because remember, that's time that they are not in direct contact with the patient. That's paperwork time. I would love to be able to track that. But there are no quality measures because there's no impact on quality. I couldn't find a single research study, Melissa, that said there was a correlation between prior authorization and increase in quality of services.
And anecdotally, that leads to a reduction in the quality of services because the clinician is taken away from actually providing services. And again, I can speak to what the process has been like for the residential treatment centers that we operate. It could be anywhere from 1 to 3 days before you receive a response to a prior authorization request. And, just the number of the requests that are going to start coming into the MCOs is going to increase, which I anticipate is going to delay that response because there's going to be more work on both ends. But I don't see it speeding up the process to get people approved for what could be life-saving services. I mean, with the overdose rates that we have in this state, even though they're going down over the years, over the last couple of years, I think that whenever you look at slowing down the access to treatment for someone that's suffering from addiction, I don't see it having a positive impact on our ability to provide quality services.
And Melissa, you may not remember, but prior authorization was restored for the residential substance use disorder services. What, Tim, about a year ago? It's a bit longer than that.
It may be closer to 2 years ago.
2 years. So that's the only one of the behavioral health services that has had prior authorization. So Tim is telling you what that experience has been. And of course, the numbers are going to go up, as he's pointed out.
And also, there's operational impacts, and then there's also the impact to patients. But like what's kind of been shared is on that administrative burden. That's going to be, like you said, Dr. Schuster, for us, it's phone calls, it's paperwork, it's appeals. And we're actually looking at measuring the cost of these administrative activities ourselves. and the frequency of the, prior auth requests and denials. But there's also a financial impact to us as community health centers. When you have denials on revenue, well, that affects our cash flow. And so we calculate the cost of delayed and denied care. We also evaluate impact on billing and coding processes, but it's just not efficient at all. And then the patient impacts obviously is that access to care. If you measure delays in patients receiving necessary treatments or medication, that's significant, or adherence to treatment plans. So we're looking at tracking the number of patients that forgo care due to, again, these prior auth requirements. But again, overall, it affects health outcomes. And we look at increased emergency department visits or hospitalizations that are due to delayed care that we could have taken care of at a primary care level. And we heard it from the hospitals before expanded Medicaid. They were talking about some of our patients that come in that, we got this, and I use the term train wreck. It's just someone that is really, really ill that's not had preventative care. So again, it has an impact on us for sure.
Well, these have been really good questions. Any other questions before we wrap up? I just want to say thank you again to all of our speakers today for being here, for your time, for sharing your experience with us. And thank you to the reporters who have joined us. If you have additional questions, feel free to email me. I can also put you in contact with anyone who's spoken today on the call. Thanks very much, everyone.
Thank you.
Bye.
Thank you.